Good morning and welcome to our webinar this morning about new ways to communicate with patients and staff during this current global crisis. As a community, we're all experiencing a really unprecedented health situation, and right here, right now, there's no more critical industry to support the community than healthcare. And ensuring that you can communicate reliably and easily is vital. So our panel today is about talking about what we're hearing from the industry and what clinics, practices, and health professionals can do to manage communication at this time. We're going to have the panel between our team at Message Media, Anthony Gerges, and Dr. John Lambert, who is a consultant to a software provider that we work deeply with, Genie Solutions. So at this point in time, I'd like to invite you to know that we are able to take questions from Anthony and Dr. John at the end of the session. Just drop your questions into the little question bar at the side of the panel on GoToWebinar, and we'll move across into our panel conversation. So, Anthony, how are you finding customers and what they're asking about from a healthcare point of view as this crisis has unfolded?
Look, it's been a fairly interesting time. I think the traditional ways of communicating for things like appointments and so forth have kind of been ingrained for a number of years now. But what we are starting to see is people evolving into, I guess, more of that kind of update-based notification around really informing people, you know, for example, if they are experiencing some sort of symptoms right now, not to come into the clinic and to respect the things like social distancing and the well-being of the doctors and so forth, but also a really big push to drive the telehealth side of things, which, you know, has been on the cards for quite a while, but obviously this pandemic has really kind of accelerated the process around a lot of, you know, solution providers, software providers, and even individual clinics, you know, looking at what ways they can provide telehealth solutions to their patients. And then obviously messaging being a key tool to, one, advise people that, you know, that is an option now, and two, also sending links out for them to actually dial into, you know, the telehealth side of things to have the consultations with, you know, with doctors and specialists and so forth. Dr. Lambert, you know, as a clinical advisor, what do you expect, you know, clinics and practices are really facing now?
To be honest, at the moment, I think it's a blend of overwhelming over-information and confusion, and not the information you require when you require it. It's this crazy blend that people are talking to us all the time, but do we really understand what's going on, and do we have the information we actually need to conduct our practice or as a patient to get our healthcare in the best way possible for us?
And how do you see things changing, you know, day to day, week to week, with, you know, providers and the like out there in the healthcare space?
Well, obviously, providers are certainly an essential service, so they're not going to stop functioning by choice anytime soon. However, to think that they're not impacted by the lockdown is crazy, because obviously, especially, well, I don't know whether it affects the small practices or the larger practices more, but staff are affected by other members of their family that might be in isolation, that might have an impact on them, family that they're caring for that may be unwell. Now, those numbers are pretty small at the moment, but of course, children not being in school by and large means that people who have kids may not be able to come into work as readily. So there's definitely going to be an impact on the team inside the practice. And then, of course, there's the big component of seeing people in the flesh, and, you know, as clinicians we're used to that, I guess, but you've heard about the logistics of getting personal protective equipment and all the rest of it. So not surprisingly, I think every practitioner is looking hard at their practice and saying, well, how much of what I do can I do without being physically in the same space as my patients?
And have you had much involvement around the telehealth side of things across either hospitals or clinics or solution providers, and how that may be evolving?
So I had extensive involvement with delivery of healthcare via telehealth in my days as an intensive care specialist, especially when I was working out in the rural location in Orange. We were providing a support service to the hundreds of GPs and small sites in remote New South Wales. We were responsible for the right upper quadrant of New South Wales. So yes, you know, I've been acutely aware of what helps telehealth be a success and what helps, what often causes telehealth not to work. One of the great things about the COVID epidemic, I guess, is that we've at last got a very strong driving force for people to try new things and to try doing things differently, which we often didn't have. Perhaps, people were quite happy in their established ways. And if you're a busy clinician who's already got a full booking list, why bother risking that or adding to your mental workload by having to deal with telehealth? But interestingly, we were able to deliver telehealth support in the most acute of conditions. I'm an intensive care specialist by training, and we were supporting other clinicians providing healthcare in remote locations to absolutely the peak of the peak critically ill patients. And so if you can do that effectively, everything else is theoretically possible. And I guess that is one thing we haven't heard a lot of discussion about in the media, which is about clinicians helping other clinicians do their job. So for instance, you could argue that specialty care may be less, with the obvious exclusions, perhaps mental health, for instance, specialty healthcare probably has a higher requirement for actually physically seeing and touching the patient. However, one mode of care that hasn't been discussed too much, it was the original supported mode of healthcare in the telehealth MBS, is to have the patient being seen by a GP or another specialist in another location, and then providing support to that clinician rather than directly to the patient. So telehealth support, clinician to clinician, to support the care of a patient is also a modality I think we'll probably see more of once people get their head around the basics.
Interesting. That's very good insight. What are the first things that you're kind of recommending to clinics and practices to do in light of everything that's kind of going on at the moment?
Look, I think the key responsibility that clinicians have is to give customized information to their patient groups of interest. Now, we've all heard about personalized medicine, and everybody thinks that's all about gene-based therapy and, working out in Gattaca style what type of illnesses you're going to have, and then custom crafting medications to treat you. But personalized medicine from the patient's point of view is also about not loading me up with a whole lot of messages that don't apply to me. Obviously they apply to somebody, but why are you wasting my time sending me this rubbish? And I think practitioners with digital practice management solutions are in a great position to do crafted messages. I'm going to look to the left slightly because I've got a bit of a list of examples and I don't want to miss some of them. But so cardiologists are a really key group. It's not exactly a rumor, but one of the things going around the net is the risk to people who are hypertensive and on ACE inhibitors or angiotensin receptor blockers. So I think cardiologists who are managing difficult to manage patients with hypertension, you wouldn't go to a cardiologist if you weren't difficult. I think they should be isolating that subset of patients in their databases and messaging them directly. For God's sake, don't stop taking your ARBs. Don't stop taking your ACE inhibitors. It's absolutely vital you continue, and the evidence does not say you should not take those medications at the moment. What about all their long QT patients? Most patients with arrhythmias will go to cardiologists. They should be saying to them, for God's sakes, don't listen to the rubbish on social media about chloroquine or any of those other medications that prolong QT. You may literally drop dead if you take these meds, so don't take them. You've got respiratory physicians who want to make sure their patients are up to date with their asthma action plans and are taking their preventatives. It's absolutely imperative that you take your steroidal preventatives, because if you aren't up to date with those and then you get sick, you're in twice as bad a trouble than if you've been taking them regularly. Geriatricians, updates on how to keep safe in isolation. All of their patients are a high risk group for COVID, so they are a particular focus area, and I think they've got an ability to be aware of community support offerings for aged people and the elderly, and make sure that their patients actually know about the existence of these services and tap into them, potentially supporting them if required. Mental health, obviously, the thing about mental health is generic. If I'm a psychiatrist, you don't want to send a generic message out to all your patients. You need to be thinking, what message do I want to give my anxiety patients? What about my schizophrenics? What about all of the various subtleties of mental health? And you really want to pick out those patient groups and send targeted messaging to them to help them deal with this issue. Agoraphobics probably going to love COVID-19, but patients who are scared of being cooped up and being isolated are not going to do so well. So those are some of the examples I've come up with, really without spending too much time thinking about it, of targeted messaging. And I think helping combat the rife misinformation and rubbish on social media is a key responsibility for clinicians. And I would recommend, stay within the domain of your expertise. You don't need to provide more messages about what social isolation is, and you know, there's lots of people doing that. Focus on, I'm a specialist in X, and I've got patients in subgroups A, B, and C. What can I add to their understanding of this and help make them safe? So I actually think that's the priority right at the moment. We still don't have a lot of cases, population speaking. I mean, you know, it's still under, I forgot, I haven't done the numbers today, but you know, there's a couple of thousand numbers, but divided by 7.5 million patients, the vast majority of your people are not going to be sick with COVID-19, and they need advice on how to stay that way.
Very, very, very good recommendations. You touched on it before, but rural practices, what would be some, you know, key considerations for people in the more rural areas that they should kind of really look out for or try and implore?
Well, I mean, you could argue in a sense that rural practitioners have been dealing with remote challenges for an awfully long time, and so they probably should be better prepared for this. I know that's a nice thing to think. It probably isn't true, but I can tell you that everything that a rural-based practitioner does to remotely deliver their practice using the tools that are now available as a response to COVID will be wonderful for the long term, because once their whole staff are used to it, I mean, some people are saying this epidemic will change the delivery of healthcare forever. I'm not so sure that's the case universally, but in the rural practice, it probably should. Like if you work out in this practice, in this epidemic, that you can actually conduct a third of your practice using remote technology, why would you not continue that? I mean, for your patients to not have to travel even 50 kilometers, but 500 kilometers to come and see you, wouldn't that be a wonderful thing for everybody? And if it's not an additional impost, you're already used to it, you've integrated into your practice management system, your PMS now has a telehealth solution, you've got messaging integrated with your appointments book, hey, why not keep using it? So I think rural practitioners should be using this as a lever to continue to use this service in the long term when people live remote to your practice because that's where they live, not because they're forced to stay there by a government edict, even if they're 20 yards down the road. Does that make sense?
Definitely. And in regards to telehealth, obviously, you know, I mentioned before that, you know, we're speaking with a lot of customers who are using, you know, messaging as a tool now to deliver telehealth to their patients and so forth as an option. And obviously, it's been heavily accelerated by what we're seeing today across the world. Do you think it's one of those things whereby it's almost, it has been like a forced shift in thinking in the way of doing practice and so forth, but do you think it will stick? And do you think it will possibly almost become more of a new way of doing things compared to the traditional method of people coming into a clinic and so forth? It's almost like Uberizing that experience a little bit more, if that makes sense.
Look, I'm a strong believer in what's in it for me. If people are forced to do this sort of uncomfortable thing and then discover that it's actually good for them, it's good for their patients, it's good for their practice, in fact, their life is better. I'm actually quite enjoying the extra hour and a half of time I get every day because I'm not commuting to work. You know, I've been working from home for 2 weeks now. And even with the gym, like I hate the fact that the gyms are closed, but I'm setting up my own gym at home. I'm trying to keep, you know, on top of my program and not be slack. But seriously, not having to travel, I go to a gym which is about 15 minutes drive away. So there's another half hour and I'm using that to do a better warm up rather than wasting time getting in a car, driving and all the rest of it. So, you know, if I keep up that and manage to make that a pattern, that's something I want to continue. Same for the practices. If they're finding that it's actually really easy to do things remotely, you may find that, okay, we've got 10 sessions a week that we provide service. Maybe 3 of those could switch to telehealth rather than face-to-face. If you've got a really slick environment, you might be able to interleave telehealth appointments with face-to-face appointments, and that actually may do some good with your waiting room queue management. One of the absolute things, I do want to actually spend some time maybe a bit later in the conversation talking about waiting rooms, because if you think about, there's all this discussion about remote practice. And yeah, sure, if you can deliver your care via a video camera, great. But I can assure you as a doctor, so much care is about touch and feeling things and things that just don't transport very well over the video connection. We're 2 talking heads at the moment. If I want to look at your big toe, it's much harder, and patients don't know anatomy. You can't direct them what to point at. There's a whole lot of reasons why a whole lot of healthcare is never going to be done remotely, in my humble opinion. Maybe when we've got really cool VR headsets for everybody, but you know, that's a fair way off. So let's accept that at least 80%, maybe, depends on the practice. Some practices may be able to go 50% remote, others might only be able to go 10% remote, whatever the number is. What about the bit that you can control, which is when they come to your practice? So I think the days of full waiting rooms of people waiting around for a doctor should be thrown out, and I hope they never come back after this. The biggest problem with COVID is keeping people in a room together. So why do we have waiting rooms? What is the point? Why not manage all that remotely? Why not have people with dynamic updating lists of what's happening with the doctor, how delayed they are, whether they're ready for you or not? You know, why not get a message 3 minutes before the doctor's finished their appointment, or even as they close off the appointment? By the time that patient leaves the consulting room and goes out to the front desk, the patient could have got out of their car, which is still in the street, and then come in, and there's absolutely nobody in the waiting room other than the two people crossing paths for that particular room. You know, I think another thing that'll change is people will look at their waiting room designs and see if they can spread them out, or you know, have multiple sub waiting rooms. That will probably become more of a trend. On top of that, you know, it'd be a great opportunity for us to learn from 200 years of engineering about queuing management. There are better ways of setting up your appointment books so that patients don't wait as long. There are tricks to do with cohorting appointments of different types so that, you know, there's some, I'm not an expert, but in queuing theory, my dad was an engineer. There's a whole lot of science about how to set up your appointment books so that you don't have queues. And we should learn from that. But even if you can't organize yourself perfectly, so there's always a bit of overrun or whatever, real-time updating of patients as to when you're ready, when they should come in, at least they're not sitting around in your waiting room. And if you're in a shopping center or something, or an environment where there's things to do outside the practice but very close by, why not let the patients do that? That's a bit more patient-centric as well. So I really do hope that better management of wait time for patients will be a permanent feature of benefit from this process. I do feel that there will be a greater use of telehealth where it is appropriate for the practice, and that's going to vary. Sorry, I keep looking at your face, not the camera, I apologize. It'll vary depending on the practice. Some practices I think will have a fairly decent use of telehealth, others probably be quite minimal, but there'll probably be some long-term change long-term. And it does a bit depend on how hard it is. And I think the great thing is that in 2020, we have a lot of tools that are so much easier to use than the stuff we had to use 10 years ago when I was, actually it was 15 years ago when I was delivering telehealth services out of Orange Health Service.
Okay. And probably a really good segue into potentially my last kind of talking point here is, you know, you've gone into, you know, the later impacts from a, I guess, waiting room telehealth perspective, but what do you see potentially are the later impacts from a healthcare point of view on the industry due to the likes of COVID?
Well, I'd like to think at a broader scale, it creates a better culture of data sharing, information standardization. I mean, a lot of the challenges we're facing with at the moment is we just don't know enough about this bug, and there are pockets of information. There is quite a bit of sharing, but you know, pre-stated consent models and approvals for sharing of information in pandemic situations should be required. I mean, even just this little suggestion I'm making about targeted messaging. How many practices actually have codified their records to allow targeted messaging? How many people actually put the diagnoses into their PMS so that they could do this for messaging? I suspect probably not as many as there should be. And, you know, this is a great time to start thinking about doing that, because now you can see the value of this. And even maybe you can, in some practices, say for this cohort of diagnoses, our first preference is a video consult, not a face-to-face. So there's a whole lot of other reasons you could use that. So I think better codification for communication, bracketing and targeting, I think will be one thing I'd like to see long-term. A greater collaborative and sharing mentality in the health system would be a wonderful outcome. And I think there may even be other benefits in terms of working from home. I mean, people don't tend to think about working from home in practices, but I used to sit in a lot of practices when I was supporting software myself 20 years ago, and there were people in the practice that didn't have to physically be there, you know, whether they be transcriptionists in the back room, accountants, practice management managers, perhaps not full-time but part-time, and the collaboration tools that you can use, you know, Teams, Slack, Hangouts, whatever tool you want, are really getting incredibly powerful. And so you may find that your staff will be happier, and you'll be able to actually have a more productive team if you take some elements of working from home and allow them to continue after the after this event. Because, you know, I think as this you're talking the long term, but I'm also thinking there's the intermediate term. So there's the next 6 to 12 months, and we may all be in lockdown apart from the practices. How are you going to deal with that when your staff are supposed to be in lockdown? Do they really have to be in the practice, and can you provide tools to allow them to do that?
That's great. I think probably...
Actually, just to that, while you're looking at questions and deciding where to go to next, there is one issue that will probably come to the fore, and it's a bit tough to deal with at the moment because a lot of the companies that you buy from are out of stock, not surprisingly. But if you are planning to do work from home, I think a lot of people underestimate the need for appropriate infrastructure. It's not very expensive. It's a drop in the ocean compared to the running costs of a practice, but providing adequate screens for people, really important. Providing computers with adequate power, RAM, CPU power. You know, when you're using Word or a bit of web browsing, it doesn't matter a damn. But when you're using video conferencing, the more RAM and higher powered processors you've got, the smoother and better the experience is. You won't get great breakup and all the rest of it. And then obviously internet connection. You may have to support your staff in having an adequate connection at home if you're going to do this regularly. And I think none of those things hurt. It's just, but I think if you're expecting people to work from home, you may have to think about how you augment their work from home experience to optimize the productivity to your practice.
That's great. Great recommendation. Thank you.
That's wonderful. At this point in time, we're going to move across to a Q&A session for this. And please do send through your questions through the panel on the and the GoToWebinar screen. So do ask whatever ones you've got. But in the meantime, we have had a few that have come through. And the first one that has come through for you, Dr. Lambert, is what is the #1 concern that you're hearing from general practice clinics and then also allied health clinics?
I'm sorry, it's probably not a question I can easily answer because I don't have direct access to them at the moment. Ironically, we're about to do some work where I was going to go out, not so much to general practice or allied health clinics, but to anaesthetists, and it's sort of been a bit put on hold because of all the demands. Everybody's frantic with COVID-19. And what I would relay is probably what you'd get from the media, which is the concern about personal protective equipment and the practicalities of managing patients in a waiting room that isn't designed for social distancing requirements. So I guess that's one of the reasons I'm thinking appointment book management, real-time updating of appointment status and waiting room status is probably a key thing all practice management solution vendors can do to help, and messaging providers can do to help practices deal with that challenge. Unfortunately, I haven't got anything I can do personally to help with the PPE and the hand sanitizer side of things. And I guess the other, from the friends that I collaborate with on social media, you know, doctors and people, allied health practitioners I've got relationships with, the government has not really sent out a lot of conflicting information, but it's then augmented or added to, is probably a better word than augmented, by mass media and social media and other purported authorities, and that causes great confusion. And you know, I think it's improved now, but we had the AMA contradicting the government at one point. We had a bit of lack of clarity about the difference between what the states were doing and the federal government. So that's made it really hard. And again, I personally can't do a lot to help with that, but those are the two key issues that I have seen, which is PPE and management of the safety of your staff and the safety of patients coming to your practice, and you know, having consistency in what should I do as a practice manager to manage this. I would remind everybody again that the actual absolute numbers of people wandering the community at the moment with COVID-19 are still very low, so the absolute risk to you individually is low, but it's absolutely imperative, of course, and this is the cognitive dissonance that a lot of people struggle with. It's absolutely imperative that everybody does the social distancing and tries not to, you know, move outside their home unless it's essential, and we shut down non-essential activities where people group together. It's absolutely essential that everybody does that, because that small number of people around the community are enough to wipe out the whole health system if we let it spread. But right at this point today, somebody coming into your practice, the chance of them having COVID-19 and impacting your practice is relatively low. And I hope by the time that changes, which probably is only a week or two away, the PPE and supply chain issues around hand sanitizer, etc., will be sorted, and the practices will have what they need.
Fantastic. And another big part of our audience today is aged care facilities. What are some of the things that you, as a clinician, you would be recommending to them to start enacting now, whether it's about their residents, the families, the residents' families, and also keeping control of their staff, particularly as those facilities are in lockdown?
Yeah. Look, it's a really tough situation because I have to be honest. Even while I was the Chief Clinical Information Officer at New South Wales Health, I kept raising the issue, well, we're doing all this great job of digitising public hospitals, and most of the practices have reasonably good internet, but what about aged care services? Like I visited quite a number in South Australia recently and New Zealand, and I've also visited a few in the UK, and it's kind of tragic. Like if you said to them, make sure that your aged population have access to methods of communicating with their families if they can't come and visit, it's like, what? Like we haven't got Wi-Fi, let alone computers or tablets anywhere, and people are often relying on 4G and 5G solutions, etc. But I certainly think a liberal policy on allowing people, and of course this it's very variable because a lot of a lot of patients in nursing home are there because they can't manage themselves, and they probably can't manage iPads and iPhones, but obviously where they can, that's a great thing to do. But working out protocols where you can help continue to provide some level of engagement for people in these places, I think is critical, because for many people in aged care homes, the sort of the primary thing they live for is that connectivity with people, and I really worry a lot about that. And it may be a bit of a wake-up call for aged care service providers to up the ante with their networks and Wi-Fi and screens and audio-visual systems that are in their rooms. I believe if they did that, that would then offer a whole lot of extra advantage. I work in AI now, and the ability of computer vision is just increasing exponentially. It's crazy how good it is now. And so things like, why would we put the cost of having a webcam in every room? Well, if you're using that webcam to detect the onset of delirium and a patient who might fall, or a patient who might be getting out of bed who shouldn't, and using the audio feed to provide artificial intelligence chat solutions, so a demented patient can have a conversation with a chatbot that doesn't care that it's having the same conversation it had 10 minutes ago and 10 minutes before that, and it can do that continuously 16 hours a day. Imagine the difference in quality of their experience would be, and you're not even employing any staff to do it. So I think there's some, happy to have a separate session on aged care. Actually, I've got quite a few ideas for aged care, but the challenge at the moment is most aged care facilities are really doing it tough on the core IT infrastructure for technology to really help them as much as I'd like it could. I'd like to think it could.
But conversational messaging, it can actually just be a really key connector for those vulnerable people, which is really important.
Yeah, and that's the thing. It doesn't always have to be high tech. So, I mean, I think texting is a bit of a challenge for older people with poor eyesight and perhaps poor finger mobility and all the rest of it, and coordination. But audio, like good old telephone calls, nothing wrong with them. And I was discussing with my partner what COVID-19 would have been like if it was pre the internet, which, by the way, in all practical senses, is only 15 years ago. So what would we be doing if we were subject to all these rules and we didn't have the iPads and the phones and Zoom and Teams and all that? I mean, Zoom and Teams and stuff, they have not been around very long. Skype has been pretty crap for most of the last 15 years. So, and she said to me, I think we'd be calling each other a lot more, talking to each other a lot more, and probably visiting within the social distancing rules and checking in on each other a lot more, which I can't say would be a bad thing.
That's fantastic. Dr. Lambert, thank you so much for that. We actually hit time a lot faster than I was actually expecting for that, and we haven't had any further questions coming through. So, look, very much, we appreciate very much Dr. Lambert and Anthony Gerges' time today, and everyone who's been on the call today. We know that it's an incredibly critical time for the health industry at the moment. We appreciate you taking the time for this. And if there is anything that we can do to give you a hand, do please reach out to either of our teams. We're here to help you and want to give you the best opportunities and chances that you have to get through this crisis. We will be sending through an email of this recording after this session today. And more than anything, thank you very much, everyone, for your time, and best of luck over the next couple of days. Thank you.
Thanks so
Everyone,
much for organising this, guys.
Thanks, guys.
And thanks for watching, anybody who did.